Beware the Ides of March. That's right. That's right. For those of you who don't remember your history, the Ides of March was the day that Julius Caesar was assassinated on the floor of the Senate, March the 15th, 44 BC. And as the story goes, he was on his way to the Senate, stopped by a fortune teller. The fortune teller said, "Don't go. Beware the Ides of March." But that was the peak of Julius Caesar's powers. He had become emperor. He pretty much thought that he was the top. So he blew it off, went to the Senate, and of course, lost his life there in a spectacularly bloody type of way. It's a lesson for all of us in the hazards of being in political power. Speaking of which, for any of the division chiefs that are here, if anybody gets upset with what I'm doing, please, we don't have to resort to that. Just tell me, you want me to step down, and I'm fine with that. But today's topic is hemophilia, which for the hematologists in the audience, I'm sure just conjures up, all kinds of pathways of clotting, etc. But quite frankly, for me, conjures up other visions of political intrigue, the machinations of the royal families of Europe, Russia, the Romanovs, Rasputin, culminating, of course, in the Russian Revolution, the sequelae of which we live with today. I don't think that Dr. Sharma is going to be talking about that. But in order to introduce our speaker, I'm going to ask the division chief for hematology and oncology, Dr. Jason Chesney, to come up, please.
So when Eleanor said that, Beth and I kind of winced because we thought she was talking about us being in power in oncology. So we were relieved when she said that she was talking about herself. This is a pretty exciting moment for us all. Hemophilia is a big problem in this region, and unfortunately, it's woefully underserved. The patients are. Vivek, I don't know if you all know Vivek. We know him as a sweetheart. He is one of the most gentle oncologist physicians that anyone knows in our division. He is well loved by his patients and by his colleagues. He's been here, I think, for about 17 years. And he started out in India. If you don't know him, he's Indian. He got his MBBS, I think I can't remember, but then I got his internship at St. Luke's and then moved here in 2001 or so and did his internship here at the University of Louisville. And things were a lot different back then. And I'm not going to go into some of those details, but he moved on to become a resident in internal medicine and then a fellow in Hem-Onc. And that's when I first met him. We rounded at, I think, Norton together, and I was a junior attending, and he was a very, very good fellow who was hardworking and knew stuff that I didn't know and taught me more than I ever could come close to teaching him. Well, Vivek became an instructor shortly thereafter, and then an assistant professor, and now he's an associate professor. He's risen through the ranks here because he's been so successful, and he's focused on clinical trials, and you'd be surprised to hear this, but the University of Louisville the School of Medicine doesn't view clinical research as research. It's considered clinical service, but I can tell you that the FDA, the National Cancer Institute, view clinical trials as research. They do award grants for it. The FDA expects us to be independent investigators, to ask all the hard questions when patients have adverse events, when responses are atypical. And Vivek has been very prolific in this role. He has been a principal investigator on 26 different trials, co-investigator on 8 different trials. He's been the one solid, continuous hematologist, oncologist who has focused on benign hematology at the University of Louisville in his tenure here. And as a result of that, he's now the leading regional expert for PNH and for hemophilia and for all the benign heme. When Dr. Yam died, it was a crushing blow to the VA system, but also to the University of Louisville. in all of our training programs, and Vivek has really picked that up. From a personal note, I can tell you when I'm on service, which happens to be this month, and I come across one of those really difficult heme cases, and to me that's usually, it's always comes down to risk benefit, right? And do you anticoagulate or not with the 24-year-old who's pregnant? The first person I call every time, and this has been going on forever, is Vivek Sharma. And why do I do that? It's not because he has, this incredible knowledge of the NCCN guidelines or can recollect what was in a textbook that was written 20 years ago. It's because he's got sound judgment. He really thinks about the case and puts it all into perspective. And he's got the expertise and the background and the experience over 20 years of focusing on benign heme. And so I'm going to stop there and just have Vivek come up, and he's going to tell us a little bit about hemophilia now in the 21st century. Vivek?
Thank you very much. And after that introduction, you can be sure that you are safe as far as you don't have to worry about assassinations or anything. But I appreciate the gracious introduction here. But hemophilia is a condition that I think many of you may have seen in the hospital, maybe even in your clinics. It's not common, but we have a hemophilia treatment center here. We have close to 200 patients between us and the pediatric hematology group. And so at some point, if you haven't seen a hemophilia patient, you probably will. And what I'm going to endeavor to do in the next hour is to really give you all sort of an understanding of what this condition really is and where things are right now in terms of management. And in doing so, we'll kind of put things in historical perspective, because as Dr. Lederer just said, that the history of hemophilia and its treatment has a lot of intrigue, a lot of ups and downs, a lot of bumps on the road. And I think you will appreciate where we are once you put that in context with where we have been with hemophilia. So let's just start with that. Here's my disclosures. They're also in the flyer. So what exactly is hemophilia? Now, most of us understand it as a condition that is associated with excessive bleeding, right? But this has actually been known for a very long time. Since ancient times, there have been manuscripts and various things that have been written describing a bleeding disorder that looks very much like hemophilia. It's been in the Talmud, the Jewish rabbinical writings in the 2nd century AD, where the rabbis said that if a woman has 2 consecutive sons that bled excessively or died during circumcision, the 3rd son would be exempt. Right? That sounds like hemophilia. The other description from a little bit later on in the 12th century was a well-known Arabic physician, Albicus, who described a family where there were many male members who had bleeding disorders, and the females appeared to be carriers. Again, sounds very much like hemophilia. And then more recently, from the 18th century in the US, there was a physician by the name of John Conrad Otto who described a family on the East Coast and traced relatives all the way back to a lady who landed with the pilgrims. And it looked like all the male relatives were the ones that were having the bleeding. So this description was there, has been there for a while, but there was no name to this condition. If people were intrigued by it, but nobody could do anything for it. There was no treatment. Didn't even know what caused it. Maybe something in the blood. People thought maybe it was blood vessels, maybe it was something else, but nobody had any clue as to what it is. So where does the word hemophilia come from? Actually, that was first described by this physician, Hopf, from the University of Zurich, in a little collection of articles that he put together, basically almost like a review article, if you will, looking at all the literature in the world about hemophilia. And he coined this term hemophilia for the first time. And the word simply is sort of a compound of two Greek words, hemo, which suggests blood or bleeding, and philia, which means affection or love. So it's almost a bizarre name that suggests the love of bleeding or people that love to bleed, which is, I think a bit odd, but that's the name that was coined. And nobody really cared because there was nobody looking at this condition. There was no other people researching it. Nobody else challenged, the name or changed the name or anything like that. So the name stuck. And in fact, that's what we call it today. So this was a disease that was described intermittently, but mostly obscure because no treatment, nobody knew what caused it, and that's how it was. Well, things took a change, a fairly dramatic change, right here in the mid-1800s. As you can see, these are publications over the decades about hemophilia, and you just see the spike going up here in the mid-1800s. Well, there was actually a very good reason for it. And again, going back to some of the historical background that Dr. Lederer was referring to, the reason why this interest was suddenly peaked was because a very famous and actually a very powerful person turned out to be a hemophilia carrier. That's her right there. That's Queen Victoria, who was the monarch of the British Empire. And she turned out to be a carrier of hemophilia. And through her, here's the family tree of Queen Victoria. So what you see in this family tree is basically, the round ones are the females, the squares are the males. The ones that are solid are the ones that are affected by hemophilia. The ones that are open are unaffected. So you can see that among many of her children, she had at least 2 daughters who were carriers, and she had one son, Leopold, who had hemophilia. And he died at the age of 31 from an intracranial bleed. But through her carrier daughters, hemophilia spread to multiple royal families of Europe, to the Spanish royalty, here through this one over here, to the German royalty, and then through Alexandra, who was the granddaughter of Queen Victoria, went to Russian royalty. And was another story that is really interesting and really quite a sad chapter in Russian history, where the 5th child of this family, the royal family, Alexei, was the only male, and thus the Tsar apparent. He had hemophilia. And here's the family. This is the Russian royal family. This is Tsar Nicholas. This is Queen Victoria's granddaughter, Alexandra. These are their daughters. Here's Alexei. Okay. And this boy's hemophilia was severe, and he bled frequently into his joints, into other soft tissues, had a lot of pain. And this became a nightmare for this family because this was a royal family, right? And this boy is being groomed to be the next Tsar. He's supposed to project a macho, strong image. And here the family realizes he's fragile. His mom has seen her uncle die of hemophilia. And so they're keeping him all protected, and they're struggling with his disease. And the strain that it's putting on them and the family as they're going through all this is felt by many historians to be one of the factors that actually enabled the Russian Revolution to succeed like it did. But there was another element to this, another interesting twist. There was a guy who was almost like sort of a mystic kind of guy, Rasputin, who was the only one who was able to help Alexei. And he would come in, he would do some hypnosis, maybe give him some herbs. We don't know what all he did, but he would calm him down, he would help his pain. And so that gave him unprecedented access to the royal family. And unfortunately, this person had a bad reputation with the public. And the public could not understand why the royal family is giving this man this much access. Because they could not explain to them, this is why we are letting him come and be with the royal family and come in anytime he wants. And so that was another thing that made the public kind of say, well, this royals are there getting corrupt. Okay. So really an interesting twist of history, but this is what made hemophilia, it brought it front and center. This little quirk of history where large numbers of people in powerful families in Europe and Russia were affected by it, and that led to an enhanced investigation of the condition and some of the things that we learned from there. And so going on from what we knew back when Alexei had this, which is basically close to nothing, we didn't know what caused it, we didn't know how to treat it, we didn't know anything about hemophilia. Let's go on now to see exactly what we have learned since then and what this condition actually is. Okay, so that's what I'm going to talk about in the next few slides before we jump into the treatment and how that has evolved. So what exactly is hemophilia? So in the simplest of terms, let's first look at what happens in the normal scenario. So normal hemostasis normally proceeds by way of a couple of phased reactions, right? Although they're happening in a sort of a continuum, but we kind of think of it as phases. There's a primary hemostatic phase, which involves vascular constriction, okay, sort of almost a mechanical pressure to stop bleeding. And then there's the formation of a platelet plug, which happens by the action of von Willebrand factor and various platelet receptors, which cause platelets to come and stick to the area that is injured and plug it up. Now, if that's all that happened, this would not stay there very long, because this is not just an empty pipe. There's blood flowing on this under shear force, and there's force being applied to this plug. So in order for it to be able to stay there for longer than a few hours, it needs to be strengthened, and it needs to be supported. And that support is provided by the formation of fibrin, right, which is done by the action of the coagulation factors. In hemophilia, what happens is that everything proceeds just like normal. If you can see, if you put them side to side, everything proceeds normally until the formation of the platelet plug. But that's where things fall apart. If you don't support this plug, it only lasts for a few hours. Few hours is not enough for the healing of the endothelium. It requires a few days in most cases, except for the most minor injuries. And so in that scenario, what happens then is that in a few hours, even though it looks like nothing happened at the time, the person starts bleeding because this clot starts falling apart. And that's basically what happens in hemophilia. Because of this, it's hopefully easy to understand that the bleeding in hemophilia, and we'll see that in the clinical context here in a minute, tends to be delayed. So in other words, it expresses itself in a delayed fashion. So for example, if somebody comes in with a trauma within the last few minutes, that person and a normal person, compared to a normal person, a hemophilic would look about the same. But give it a few hours, and the person with hemophilia would have a huge hematoma, maybe even a compartment syndrome, whereas a normal person would not. Okay, so that's what happens with hemophilia. It's delayed bleeding. And the other thing about hemophilia is that the bleeding is deep-seated. It's in joints and soft tissues like muscles and so forth. That's what the bleeding tends to be. So this fibrin, as we know, is made by the coagulation cascade. And I promise I'm not going to show you this any more than this one time. But it's actually the only thing I want to point out here is that the end game here, the goal of this system, is to make fibrin, to stabilize the clot. And the way the fibrin is generated is by the action of thrombin, which is converted from prothrombin by the action of all these different factors. Without getting into too many details, I just want to point out that these factors here, factor 8 and factor 9, are part of what we call as the amplification loop of the coagulation system. And they are very important in an effective generation of thrombin. So once there's a trauma, there's a triggering of this cascade, this system kicks in and starts making more and more activated factor 8 and 9, which generates more and more activated factor 10. Small amounts of factor 10 are not going to cut it. You need large amounts when there's a significant hemostatic challenge. And that in turn generates sufficient thrombin to make the fibrin that is needed to stabilize the clot. But what happens in hemophilia simply is that there is an absence of either factor 8, which is hemophilia A, which by the way is more common. About 80% of patients with hemophilia have that. or there is absence of factor IX, which is hemophilia B, also called as Christmas disease. That is based on the patient that first had it and that they named it after the patient. But now it's called hemophilia B. So these deficiencies happen because of mutations on the X chromosome. Both these genes, the gene for factor VIII as well as factor IX, are both located on the X chromosome. And these diseases clinically look indistinguishable. If you did not know that the patient had a deficiency of one or the other, you would not know which one it is. They look exactly the same clinically. Okay, so that's what we now know causes hemophilia. How common is it? It's not very common, but about 1 in 5,000 male births are associated with hemophilia. And in the US, there's currently, the estimates are there's about 20,000 males living with hemophilia. Worldwide, that number is close to about 500,000. Okay. And it occurs everywhere in all races, in all ethnic groups. How do we make a diagnosis of hemophilia? So obviously, we know it's a familial disease. So if there's a family history and you know that somebody has family members with hemophilia, it tends to make it a little bit more easier when somebody presents with a bleeding disorder, but the family history may be negative in many patients. Up to 30% of patients with hemophilia can have a new mutation. So in fact, that is what was felt to be the case with Queen Victoria, is that she had a new mutation because there was no history of hemophilia before that in the royal families. So family history may or may not be present, but the symptoms, which are very classic, joint bleeds. If you see somebody with recurrent joint bleeds, there's almost nothing that does that other than hemophilia. There's a few other things. Occasionally you can work that out, but for the most part, that's mostly hemophilia. And then finally, once you suspect it based on the symptoms, the way you establish and confirm your diagnosis is by actually checking the factor levels, because you need that not only to confirm the diagnosis, but to also know which kind of hemophilia it is, because that's how you're going to treat the patient. So the factor assays help with making that diagnosis, but there's one other thing that the factor assays do, which is very important, and that is it tells us where these patients fall on the range of severity. And here's what the breakdown is. So if somebody has undetectable factor levels, less than 1%, they're called severe. If they have 1 to 5%, they are moderate. And if it's greater than 5, usually 5 to 25, sometimes maybe a little bit higher than that, but that's mild. Now, what does this mean? Why do we make this classification? Does it mean that if somebody comes to the ER after a car wreck, can we just say if they're mild, we can kind of go easy with them, let them go get x-rays, and then we can deal with them? The answer is absolutely not. That is not the reason for this classification. This classification does not apply to patients who are undergoing a major hemostatic challenge, like trauma or surgery, because for that, the levels that are needed for hemostasis are close to 100%. So patients with mild hemophilia will bleed and die just as much as patients with severe hemophilia if they have been in an accident or if they undergo major surgery. So what is the reason for this? The reason for this classification is to tell us the risk of spontaneous bleeding in these patients. A spontaneous bleed is a bleed that happens without any kind of a triggering event, no trauma, nothing that the patient can recall. So it's like somebody just maybe sitting on a chair and they get up to go to get something from the fridge and then notice their knee is swelling up on them. That's a spontaneous bleed. That happens in patients with severe hemophilia anywhere from 1 to 2 times a week. Okay, so you can think about that, almost 5 to 8 times a month. If you go just from 1% to 1 to 5%, that goes to about 5 to 8 times a year. So the incidence of severity of spontaneous bleeding drops quite a bit with just a slight increment in factor level. And then if you go to 5% or over, they do not have spontaneous bleeds at all. They only bleed with trauma. So this classification helps us to know who are the patients who are at the highest risk that we need to follow closely and that we need to give factor, etc. But keep this in mind, because this principle applies to what we're going to talk about in just a minute, which is the principle of prophylaxis with factor, and we'll look at that in just a minute, as well as the idea of certain novel therapies like gene therapy. If you think about it, one of the challenges of gene therapy is the expression of sufficient amounts of the gene product. And here, you don't need a lot of expression to change the phenotype of a person from somebody who bleeds frequently and has horrible joints to somebody who, behaves like a mild hemophiliac who doesn't bleed frequently. So this principle is important to understand. Now, given this, once you have the diagnosis, what are some of the things we look at? What are some of the things we see in patients with hemophilia? I've already kind of alluded to it, but let's kind of look at that a little bit more. So the main problem, as I said, with patients with hemophilia is bleeding into joints. And the most common joints are the hinge joints. So the knees, the elbows, the ankles are the ones that are affected the most. And this is the thing that really destroys these patients' quality of life because this causes pain and swelling. But not only that, once blood gets into the joint, it brings a lot of other stuff in there that's bad. And it starts causing an inflammatory reaction, almost like rheumatoid arthritis, with the formation of a pannus-like synovitis, which destroys cartilage. And this is sort of a summary of research done by various groups over a long period of time that found some of the things that happen at a molecular level in these patients in their joints. You have increase in inflammatory cytokines. You have expression of proliferative genes, which causes the synovial hypertrophy and destruction of the cartilage. So all of this then is what causes this progressive joint damage. And what happens is once a joint is damaged, it is more prone to bleeding again. And so it sets up a vicious cycle. And that's what causes these patients' joints to be destroyed. Many times, by the time they're in their early teens or at the most early 20s, these patients need a new joint. That's how bad it gets with the severe hemophiliacs. And the pattern that you see is sort of summarized here, where it starts out with a bleed, and the patient obviously has swelling and pain. And then it starts causing cartilage damage. And once that becomes established, the patient has restriction in their joint mobility, and obviously that causes muscle weakness, muscle wasting, and they end up with joints that are basically look worse than 90-year-old patient's joints. And this person is probably a teenager or in the early 20s, and their joints are totally destroyed. So this is what these patients have been dealing with as a big, big problem. Now, can they bleed in other places? Absolutely. They can bleed in other soft tissue areas, and they can also have potentially limb and life-threatening bleeds, such as a patient here that has a muscular bleed, potentially putting them at risk for things like compartment syndrome and so on. So you can see why this was such. Imagine having this kind of situation in the days of Alexei, when there was no treatment. You didn't even know why this was happening, and there was nothing you could do for it. I mean, these patients had a horrible life, which is why many physicians just kind of ignored it and just said, oh, well, we'll just treat them comfort care and just move on. One other thing that used to be and still is a significant problem is intracranial bleeding. Back in the early days, when we did not have good products for treating these patients, the mortality with this was 70%. And this is even during the time where we had blood and plasma. Even then, the mortality was close to 7%. It is still around 20%, but the incidence now is much lower. It's about 2 or 3%. Back then, the cause of death in about a third of the patients with hemophilia died from intracranial bleeds, back before we had better treatments. So, this was a considerable problem even in the 40s and 50s, when we actually found that there was a protein in the blood. They called it anti-hemophilia globulin because there was no other name. They didn't know what it was exactly, because factor VIII was described later on. And so they said, well, it's in the plasma, so we know it's in the plasma. So if you give people blood and if you give them plasma, then we can treat this. Problem with that was that blood transfusions are not, giving whole blood, it's not an easy thing to do. And it has other problems and complications. Number two, if somebody has 0 factor VIII, you're going to need 3 or 4 liters of plasma to get them up to a level that is anywhere halfway decent to treat a bleed like this. Okay, so because of that, in spite of getting plasma, I mean, they would have to go to the hospital. They would have to get started with plasma and get liters and liters of plasma just for one bleed. And by the time they got done with it, and they got, equivalent to what you would call today as 1 dose of factor, their bleed had already expanded. The damage to the tissues, joints, anywhere else was already done. Maybe it helped them to survive, and then end up with joints like we just saw. So this is what the situation was until the 60s. Well, there was again a serendipitous twist in the 60s, where Dr. Judith Graham Poole discovered cryoprecipitate, and she found it kind of in a strange way that she had some plasma that she had frozen, and then I think her electricity went out and it had thawed out, and there was this junky looking dirty material at the bottom which she thought is something that we probably should throw it away. It's probably fungus or something. Which is, let's examine this, let's see what it is. So she analyzed it, and it turns out that it was a highly concentrated form that had these factors right here: factor 8, von Willebrand, fibrinogen, and factor 13, highly concentrated. And so this really was a fairly significant advance for hemophilia back then. Hemophilia A, not B, because hemophilia B is factor 9, and you don't have factor 9 in cryo. But for hemophilia A patients, they could now get a fairly decent dose with a much smaller volume. And that became a significant improvement in their quality of life. There were even home health people that could go out and infuse them at home because it was a smaller volume. And that started looking like a favorable, positive thing. And things got even better when companies figured out, by then in the 60s, factors were described. We knew what factor 8 was, what factor 9 was. The coagulation cascade was published in Nature, so we knew a lot of those things. And the companies, pharmaceutical companies, figured out ways to extract factor from plasma. So they would run the plasma. They would have basically antibodies and other peptides to pick up the molecule of interest. And so they could pick up factor 8 or factor 9. And then, they would concentrate that, wash it out into a container, and then have a highly concentrated form of factor where in a vial you could give a person a dose of that factor, which would require previously 4 to 5 liters of plasma to give. Okay, so this was a great advance. This now moved patients' care to not only from the ER to home, it actually moved it to basically, where they could do it themselves. Many of them started learning how to self-infuse, how to give themselves factor, and was a great time in hemophilia. I think a lot of optimism that was there. But one of the things that was happening at this time, remember this is the late 60s, early 70s, was that there was a disaster brewing in the blood bank system, and that was HIV and hepatitis C. Nobody knew what HIV was. Nobody knew what hepatitis C was. They used to call it non-A, non-B. And the blood banks were not really checking for any of this. They didn't know about what to check for. And just to give you an idea, in order to make one of these vials, plasma would be pooled in these large centrifuges. And how big they are gives you, this is a man standing here, adult man. And these centrifuges are huge. These containers have plasma from thousands of donors. And you take a lot from that, and that one vial has contributions literally from thousands of donors. And so a severe hemophiliac who bleeds a couple times a week was taking 2 or 3 doses, maybe even more, a month. Okay, even if they're taking on-demand. Forget about prophylaxis. Okay, they were being exposed to large amounts of this plasma. And so, not surprisingly, the hemophilia population is the one that really came down with these viral infections. Over 50% of hemophiliacs got HIV, and over 90% got hepatitis C. This really devastated this whole population. And if there's a face we could put to this, especially in this country, this is it. Ryan White. People that are here from, I think many of you all may recognize this name, but people that are here from ID, I'm sure are familiar with the Ryan White Act, which was initially enacted by Congress in 1990, named after Ryan White, for supporting people living with HIV/AIDS in the U.S. Ryan White was a hemophiliac who got HIV from a tainted factor vial, and he was living at a time where scientists and medical professionals started learning a lot about HIV, but we didn't have good treatments yet. And but the education in the community was very poor. So he went through hell, literally, because the school would not let him come because they thought that any kind of contact would cause HIV. And he had to basically move. His parents had to move from where they lived. They lived in Kokomo, Indiana, and they had to move to another city to actually be able to let him go to school. But because of all his experiences, a lot of this became very public, what he was going through, the battles that he was going through with the schools. So he had a lot of celebrities that came, got him on their shows. He met with President Reagan and was a big advocate for the education about HIV. And that's what the Ryan White Act comes from. But this was obviously a major disaster in this community, and it really changed the blood bank and how they do business. But also, it drove the research even more to try to find alternatives to plasma-derived products. And in the early 90s, actually in 1994, the first recombinant factor VIII product, Recombinate, was approved. And that is now the predominant way that we get factor. It's mostly recombinant. And here's just a simple representation of how these products are made. On the left side, you see the plasma products. I already showed you how that is done. You spin down the cells, you get rid of the cells, and you purify the factor of interest, and you package it into vials, and they're ready to go. The recombinant products, on the other hand, there's no plasma involved. They're bioengineered cells. Chinese hamster ovary cells are the ones that are used most commonly. And there's a vector that is put in here, which contains the gene of interest, which is factor 8 or 9. And those cells are grown in the culture medium, which has fetal calf serum to grow it. And once the factor is produced by the gene that is in those cells, that factor is then pulled out, like would do with the same techniques that are used here. And you get pure factor 8 that is then stabilized in human albumin. That's the first generation product. This population of patients was so averse to any kind of animal product that gradually now we have come to a third generation recombinant product where there's no fetal calf serum in this. It's plant protein medium that is used to grow these cells. And in the final product, it's actually basically just sucrose. There's no albumin in that. So they've wanted to get rid of as much animal protein as they possibly can, just because it's almost like PTSD. It's almost like a collective PTSD that this community has had with what happened in the 70s and 80s with HIV and hepatitis C. They're very, very gun shy of unknown things floating around in the blood system. By the way, just as a side note, since the 1970s and 80s, there has not yet been a recorded incidence of some kind of infectious transmission with plasma-derived product. And in other parts of the world, this is still used quite a bit. But in most developed countries, we are using a lot more recombinant products. So this is how the products have come. So we have come a long way from having nothing to using plasma and just trying to get large volumes of plasma into patients, to now having not only packaged concentrated factor, but having factor that is safe. And so we've come a long way from the days of Alexei and also from the days of Ryan White. Okay, so there's safe and effective products that are available now. So how are we doing? How is the current management? How are we using these products? So there's a couple of things I want to point out here. One is for everybody here that may see these patients in any situation, right? It's just the acute setting. When somebody comes in, they're having a bleed or they're having some other problems, the main thing to keep in mind is, first of all, don't do any harm. Don't give them things that are going to cause them problems. This may seem obvious, but this is the things that have actually been done to hemophilia patients, which is why it's a statement that needs to be made. The other important thing is that if a hemophiliac comes in and tells you that they're having a bleed, even if you don't see anything on clinical exam, believe them, because they can actually feel the bleed even when it's very, very preclinical and very small. There have been instances where patients have come in complaining of having a bleed in their thigh or somewhere, and the emergency room physician checked, did a clinical exam, didn't find any bruising, didn't find any change in the girth of their leg, and sent them home, only for the patient to come back a few hours later with a very swollen leg and having compartment syndrome. Okay, so listening to the patient is very important because they know when they're bleeding. And then this is really common sense, that if a patient with hemophilia comes in with anything, and if you're needing to do a workup or do imaging, anything else, make sure you get them up to a safe level of factor. And when unsure, get them up to 100%. Now, of course, for that, you need to know what kind of hemophilia they have, whether it's A or B. But that's the thing that is the bottom line, is that you don't want to start doing stuff until you make sure that they're safe from the standpoint of their bleeding disorder. Now, this is what we do in the acute setting. What about managing these patients through all their life? Because remember, these people, I just showed you what happens to them. They have recurrent joint bleeds, especially when they're severe, and even some moderates. And they're at risk for other severe bleeds, including soft tissue and intracranial bleeds. So what can we do to manage these patients lifelong? So there's two strategies. And one of them is what has been used for a long time, and it's probably still used in most countries, is what we call as on-demand treatment, right? And that is simply that patient feels the bleed coming on, they're trained to immediately get IV access. They can usually do it themselves. Most severe hemophiliacs, by the way, have learned to self-infuse. They can start their own IV and they can infuse themselves. But then what we have realized is that prophylaxis, meaning using factor concentrates to prevent bleeding, is actually a better way of doing this. And the idea here, again, is that if you get somebody's level from even less than 1% to even 1 or 2%, you change their phenotype. They're no longer going to bleed weekly or even a couple of times a month. Their bleeding rate may go down to a few times a year. So just a little bump in that may have a big impact on their bleeding tendency. And if you stop joint bleeds, you stop one of the biggest morbidities in these patients. And by the way, prophylaxis has also been shown to reduce the incidence of intracranial bleeds, which is particularly horrible in patients in pediatric age groups. Because not only is it an immediate risk in the acute setting, it becomes a risk of chronic problems because of psychomotor retardation that happens in the pediatric age group. So this has actually been studied now, and I don't want to go into the details of this because we don't have time to do that here, but if anybody is interested, here's a paper that was published over 10 years ago now, comparing aggressive on-demand therapy with prophylaxis in young boys, and this was a pediatric study. And what they found was that even very aggressive prophylaxis, when they measured the joints with MRIs after about 3 or 4 years, 50% of the patients had already got joint damage with that. But the ones that were on prophylaxis, only about 7% or so had joint damage. Okay, so clearly this is the way to go, and this is increasingly becoming the standard in most countries, most developed countries anyway. It's not cheap. The cost difference between on-demand and prophylaxis is about 4 to 5-fold. So it is much more expensive, but in the long run, it translates into a much better quality of life for these patients. So because of these advances, the lifespan of patients with hemophilia now, and this is some data from the CDC, is that it has now, especially since the 2000s and beyond, is actually come pretty much close to the average normal population. And so that's a great thing. That's a success for us in terms of our treatment. It does bring up some additional challenges, which we have to deal with, but this is an achievement compared to where things were in the early 1900s, in the days of Alexei, where we had no treatments and most patients died in their teenage years. The other thing to keep in mind is that even though this looks great, right now, this is only about a third of the patients of the world in the developed countries. The majority of hemophiliacs are still living in this area right here because they don't have access to this. It's very expensive. Okay, so that's still a problem globally. But people that live in developed world hemophiliacs, their lifespan is close to the normal lifespan. The other thing that has really evolved, especially since the 70s, is the hemophilia treatment centers, which are centers of excellence that have a multimodal group of providers that work together to provide the best possible care, both in terms of medical, social, physical therapy, and other things like that. It's called the Hemophilia Treatment Center, HTC, and these are federally supported centers. There's about 140 of these in the U.S. Right now, and our center is one of them. And there was a study published in Blood in 2000 that actually compared the outcomes of hemophilia patients treated at HTCs versus non-HTC settings in the community. And it actually showed not only improved outcomes in terms of their quality of life and other medical outcomes, but actually an improvement in survival in that study. So the majority of patients with hemophilia now in the US are treated at HTCs. So in closing, I'm going to just pause for a minute and say, let's look at where we have been. We've come from just 100 years. Alexei, that I told you about, was 100 years ago. And by the way, he didn't die of hemophilia. He died actually 100 years ago. It'll be 100 years in July. In 1918, that entire family was assassinated, executed on the same day by the Bolsheviks. Okay, that's how Alexei died. But we have come a long way from that time to now, where patients are living pretty much a normal lifespan. They have products that are safe, that are effective, that are easy to use. They have small volumes now. They have products where you can get the whole volume in 2 or 3 cc's, and you can infuse that. So where can we go from here? Are there any issues? I mean, can it get any better than this? Yeah, the answer is there's always room for improvement. And here's some things that I think are still issues that we need to work on. One is that even though things are good and prophylaxis really works and it improves these patients' qualities of life like night and day, but it is clearly a challenge. Think about having to do IV infusions on yourself 2 or 3 times a day, 2 or 3 times a week. I mean, that is not an easy thing, especially even if you're not having a problem. That's what prophylaxis is the idea is to not have problems. If you're feeling fine, you have to then be disciplined enough to go there, get the IV kit out, start an IV on yourself, infuse yourself, and do this 3 times a week. Not an easy thing to do. Creates a significant burden. There have been a lot of studies that kind of study this burden on patients and families and doing this kind of thing. And that is one of the reasons why the compliance and the adherence to this is not 100%. And many people don't do it regularly, and that's when they have breakthrough problems. They have bad joints because even though they are technically on prophylaxis, but they don't do it regularly. Not a surprise to anybody here, right? I mean, people are non-compliant at times, even with oral medications, and much less think about giving themselves IV for the rest of their life, 3 or 4 times a week. So we need something that is a little bit better, that somehow is able to ease the burden of this. And I'll show you some ideas that have been looked at on that. We're not going to go into much detail on this because this is a whole day symposium here, but patients with hemophilia, about 30% in factor 8 and about 3 to 5% in factor 9 can develop antibodies against the infused factor. Usually not a problem in adult patients. This is seen predominantly in pediatrics. By the time they come to us, the peds people usually have done a good job of tolerizing them. They put them through these various regimens, immune tolerization regimens, and the vast majority of them are tolerized by the time they come to us. So not a big problem in the adults, but a significant problem in the children, which we are still kind of battling with because the regular factor products don't work in these patients. You have to use the so-called bypassing agents, where you basically bypass factor 8 and 9, and you pour things into the common pathway. So you activate thrombin through things like high-dose recombinant factor 7, or a product called FIBA, which basically dumps thrombin directly into the blood. Okay, So those are the so-called bypassing agents. Not great agents, can't measure them, don't know how to measure their activity, except clinical response. So this is still an area of a lot of challenges that are being dealt with. Fortunately, not as much of a problem by the time they get to the adult setting. And another area that is increasingly becoming an issue is as these patients live longer and longer, we are seeing that they're coming up with patients with conditions that we didn't see in hemophilia earlier because most of them died in their teens and 20s and maybe 30s and 40s. So now we're starting to see patients live up to 60s, maybe even 70s and older, and we're starting to see some things that we didn't see in hemophilia before, and we have next to almost no data as to how to manage them in hemophilia patients. The problem is that the numbers are small. It's difficult to do randomized trials. But what we have is databases that are trying to at least answer this question in a rational way. We have expert opinions based on people that deal with large numbers of patients, have access to large databases, and that's all we have right now. So that's some of the challenges we are working on. A good problem to have, but something that we do need to work on. So the only thing I'm going to focus on in the next about 5 minutes is to tell you about what we are doing about this, because this is something we can still work on. So here's what we have done. Said they have to give this product IV, right? People try to say, we can make it simpler if we can make it sub-Q. That would be great. If you don't have to start IV lines, just give it subcutaneously. Well, they've tried every which way they could. Companies have even made foams and certain polymers and tried to insert them like a depot and try to do it. Doesn't work. Factor 8 and factor 9 are not bioavailable to any medically significant degree through subcutaneous route. You have to give it IV. So then if that's what we are stuck with, so then the next question is, can we do something to the molecules to make them last a little bit longer so that, yeah, they got to start an IV, but maybe they don't have to do it 2 or 3 times a week. Maybe they can do it less frequently, right? So that's what was the next step. And these products are actually on the market now. I don't want you to look too much at this side here, okay, because this is just different molecules and showing what has been done to the factor VIII. They've used pegylation and, a variety of other manipulations with the molecule to make it last longer. And as you can see here, what is shown on this side is what I want you to focus on, is that this is the half-life increment compared to native normal factor VIII. It's not a great benefit here that you can see. It's only about 1.5 hours, 1.5 times improvement. So going from about 8 to 12 hours to about 14 to 18 hours. That's it. So it goes from 3 times a week to twice a week. Not exactly a home run. And so this has not worked very well for factor VIII, which is really the majority of hemophilia patients. But we have these products out there. It's being used by some patients. But it has worked. This approach of modifying the molecule to last longer has worked a lot better with factor IX, which already has a longer half-life. Its half-life is about 18 to 24 hours. And when you multiply that, it goes to days. And there are people with hemophilia B who can now dose once every 2 weeks, even, with these factors. So this has made at least some of quality of life benefit in some of these patients, but they still have to use IVs. So can we get any better than that? Can we get to anything else? And the answer is yes. There is an attempt to do just that by developing treatments that are not factor at all. So the way you get subcutaneous dosing is you have to find something other than the regular factor 8 and 9, because those don't go through the subcutaneous route. And I'm not going to go into the details of this, but let me just point out that this antibody, bispecific antibody, it's a very interestingly designed molecule. It's called emicizumab. It has the 2 FC portions, the 2 FAB portions actually target 2 different antigens. One targets factor 9 and the other one targets factor 10. So if you think about factor 8, what does factor 8 do? It's a cofactor for factor 9 to activate factor 10. So factor 8 brings factor 9 and 10 together and makes factor 10 to get activated. But what this antibody does is that it grabs factor 9 with one hand and it grabs factor 10 with the other hand and it brings them together. And so it's basically working like factor 8. It's a very, very smartly designed molecule. It's a factor VIII mimetic, and it works great by subcutaneous route. You can give it once a week, and it's actually approved right now, and it works very well in patients. These two here are doing something very interesting, and that is to knock down the anticoagulant part of the normal blood system. So think about this: knocking down antithrombin levels. This is an interfering RNA called fitusiran that has knocked down antithrombin levels to very low levels, less than 20%. Which, if we think of that almost as risky, right? That's the kind of thing that would cause patients to maybe have thrombotic events. But what the rationale for this was that they observed some patients with severe hemophilia who did not bleed, even though they had levels that looked like they were in the severe hemophilic range. Their bleeding pattern was not. And so they felt maybe there's something else in these patients, and some of those patients were found to have procoagulant mutations, like factor V Leiden and so forth. And so because of that, they tried this idea to say, well, it's an imbalance in the system, right? So if people have if they have a missing coagulation protein, then there's an imbalance where there's more anticoagulants and less coagulant. And then if there is a normal coagulant, but a missing anticoagulant, then you have an imbalance there, and that's a prothrombotic situation. But if you have a low anticoagulant, a low procoagulant like factor VIII, and you reduce the anticoagulant as well, now you get a balance. And that balance may allow the patient to not bleed. And interestingly, it's been working in some of the early clinical trials. Now, still very early. We still have to see how things pan out with this. But this is now a molecule that, again, can be used either once a week. There's even studies that are looking at using it once a month. It has a very long half-life. So all these strategies are potentially coming where these patients might be able to go to not just IV infusions every 2 or 3 times a week, but a subcutaneous infusion once a week or maybe even once a month. So that's great. But finally, last but not the least, there is now significant advance going on in the area of gene therapy for hemophilia. And this is simply the concept of how we make the product, the factor 8 or 9 in the lab, in those Chinese hamster ovary cells. Well, we can take the gene, and if we can deliver it to the cells in the patient's body, they can make the product and just put out straight into the body, right? Makes a lot of sense. And it's a disease where all you need is a little bit of expression to get benefit. But this has been a big challenge. And without going into the details, there was lots of ups and downs, technical challenges with the vectors, how to package things. But more recently, within the last 10 years or so, we've had some really exciting developments in the area of gene therapy, both with hemophilia A and hemophilia B. Hemophilia A was a bigger challenge because factor VIII is a much larger gene, much larger molecule, and it was harder to package in the vectors. But this one company has developed a product which is now being studied, gene therapy. It's BioMarin. It's a B domain deleted product. And the expressions, it's a small study presented initially at the World Hemophilia meeting in 2016, where you can see that expression of factor VIII is greater than 50% in the majority of patients. Some of them even going up to normal levels, even supranormal levels. And this follow-up now is updated, and as you can see here, what you're seeing here is about 7 patients still. And this gray zone here is the factor levels on the y-axis. And you see 60%, 150%. And as you can see, over time, most of the patients are staying in this really, really good range where they definitely have no risk of spontaneous bleeding. But even with the risk of traumatic bleeding is dramatically reduced in patients. Some of them are pretty much at normal levels. So this is very exciting. Right now, there's similar results have been seen with a factor 9, although not to this level. It was close to 30% or so in that study. But it remains to be seen how long this will last, whether this expression will remain for how many years, we'll see, and then whether this is something that can be redone, which is a big challenge right now, because if you treat them one time with that vector, once that expression is gone, you can't retreat them again because the immune system will not let you. They develop antibodies that are too high for retreatment. So there are lots of hurdles and challenges still, but I think this is an exciting time where not only are we preventing bleeds and keeping things safe for the patients, we are potentially getting to the point where now we can even start thinking about making things even more convenient for these patients in terms of subcutaneous therapies and possibly even something like gene therapy, which people are throwing out the word cure. I would use that with I would put a lot of caution on that. I don't think we can use the word cure yet with this, but it is probably the step that is the closest to that. So with that, I will close, and hopefully there's time for a couple of questions. Thank you.
Thank you. That was absolutely splendid. I just have one question to start things off. From what you've described, I would guess that the female carriers have no phenotype. Is that correct, or is there anything?
Yeah, so that's a great question. So the female carriers, for the most part, don't bleed because most of them have at least 50 to 60%. You would think that that's what they would have, but there are female carriers who can actually have levels that are close to mild hemophilia. The reason for that being lionization, because the females that are carriers, they have one X that is normal and one X that is mutated. But in the somatic cells, there's a random inactivation of one X, supposedly random. And if the majority of inactivated X chromosomes are the mutated ones, then she'll have almost close to a normal level, close to 100%. But if the majority are the normal X's, then the ones that are active are the mutated ones. And those carriers can actually have levels that are in the mild hemophilic range. That's a great question because we sometimes hear about carriers who have been treated improperly because of the wrong impression that they don't bleed. And that's not true. Carriers can bleed because their levels can be in the range of mild hemophilia at times.
Okay, great. Any other questions?
Yeah.
Following up on Dr. Letters, do you ever see a female child from hemophilia parents who have patients on both ends? Do they ever survive?
Female child, yeah. So it's rare, but it can happen. So if it's a hemophilic father and a carrier mother, you could theoretically have a female hemophiliac. It's been reported. Yes, they do have much more severe bleeding, but now with the availability of prophylactic factors, they can usually make it through menstruation and childbirth and all that. But previously, in the olden times, absolutely. Those patients usually died after menarche, shortly after menarche.
Okay.
But now they yes. Oh yeah.
Right from year one,
Yeah. No. So in terms of males and females, there's not going to be much of a difference there in terms of the severity of the joint bleeds. It's going to be the same because the males have they only have one X, and that's gone. So the severity is going to be the same. The problem with females comes in during menstruation and childbirth. So during the pediatric age groups, in developed countries, it's a standard of care now to use prophylaxis for all severe hemophiliacs. So if somebody has severe hemophilia, he or she will be on prophylaxis, and that should prevent joint bleeds. And then when she gets to menarche, she'll probably have to use a little extra factor during her periods and during childbirth and things like that. But it's not a problem because of the new factors.
Yes.
Just thinking of the label, like you say, like a patient with hemophilia who has history of spontaneous bleeding in the past and bleeds affected in the past. Now with that, we are like say with a pulmonary embolism or an FPL with like is there anything specifically as an internet we could be cautious with before we start
Yeah. So that is the conundrum we deal with, right? There's no great answers to that, but I'll tell you what the expert opinion is on that. Okay, so what you want to do there is in the acute setting, you want to get their factor level to 100% or greater, and then you do whatever you need to do. If you need to give them heparin, if you need to give them thrombolytic therapy, just make sure their factor level is 100%. So you have to have a good lab that can turn around stat factor levels. And if you're not sure what the level is, dose it to get up to 100%. And beyond that, the challenge, that's actually not that hard because you can do it in the short term, in a few days. The challenge is, what about the long term, over years, when they have to take aspirin or some kind of anticoagulant? What do you do then? And that's where the data is not that helpful. But in general, the recommendation is that if somebody is on therapeutic anticoagulation, you want their factor levels to be around 30 to 40%. And so they cannot do every other day. They have to do almost daily infusions of factor. Maybe some of these newer agents, which have, or maybe gene therapy and things like that, will help patients like this to maintain higher factor levels. But that's all you can do. We had a patient similar to what you described who had a PE, and he took anticoagulation for 6 months, and he was on factor every day during that time, and he was kept at around 30 to 40%, and he did okay with that. He did not bleed. So, but that's all we have right now is just limited data, expert opinion. But that's the recommendation at the present time. When you order it for the lab, if you order it stat, the lab should get it back to you within 1 to 2 hours at the most. But you should order it stat, because if you don't order it stat, they will send it to a routine channel, and that takes a couple of days probably. So make sure you order those levels stat.
Okay, thank you very much.
All right, thank you.